anybody knows me, I really hate public speaking, but Wendy kind of totally twisted my arm. So if I pass out, what better place to pass out in the awesome group of nurses and physicians. But I recently finished my doctorate, and this is the project that I did my thesis on. So we're going to talk a little about the impact of vancomycin powder in surgical infection, surgical site infection post craniotomies. I have no disclosures. Before I get started, I wanted to introduce the team that helped me through this. My chair was Dr. Bassos over at UNF. My co-chair was Dr. Cindy Cummings. My mentor was Dr. Hannell. The SSI task force, as well as the research team, definitely helped me through it. A little bit of background. To prevent devastating outcomes post-craniotomy, complications must be identified and intervened upon in a timely manner. One of these complications requiring immediate recognition is post-craniotomy infections. In the neurosurgery literature, the rates of infection described range anywhere from 0.7% to 12%, being most commonly caused by the Staphylococcus species. It is postulated that routine use of cephalosporins for prophylaxis had led to rising resistance in these pathogens. Consequently, several U.S. Neurosurgical centers have observed increased rates of SSIs. A retrospective study included over 5,000 post-craniotomy brain tumor resection patients. The investigation revealed the occurrence of postoperative infection was about 6.8%. Additionally, the study divulged other risk factors for post-craniotomy infections included being younger than 45, cases lasting longer than 7 hours, if hardware was placed within the brain, or if a cerebrospinal fluid leak occurred. Also, another thing that was discovered is the location of the tumor within the ventricles or infratentorially. A prospective study revealed post-craniotomy site infection can occur between 2.2 to almost 20%. This concern related to surgical site infection after brain surgery is what occurs after the discovery. Once infection is detected, subsequent and challenging treatments, including potential removal of a section of the skull, as well as antibiotic administration for an extended period, can ensue. The additional treatment modalities can incur an extra cost of greater than $500,000. In general, post-op infections can cause an additional 1 million days in the hospital, as well as 1.6 billion extra healthcare costs. We do have current interventions employed for prevention of these types of infections, which are utilized in pre, intra, and post-operative phases. Currently, in the pre-operative preparation, it includes using CHG wipes the night before surgery. A prospective cohort study included general vascular and orthopedic surgical patients washed with the wipes the night before surgery, decreased postoperative infection by about 2%. Intra-op and post-op antibiotics via IV is another common intervention. And the concern for utilizing the IV antibiotics is the potential side effects on vital organs. However, a cohort study evaluating prophylactic use of antibiotics did decrease the incidence of postoperative infection. Postoperatively, several institutions recommend washing the patient's hair on postoperative day 2 or 3 with shampoo and pat drying the area. The rationale of washing the patient's hair soon after the craniotomy is to decrease SSIs. However, a study evaluating shampooing the hair approximately 72 hours after surgery versus monitoring the dressing site revealed that there was no significant difference. Due to the strain of surgical site infections have caused on medical institution, and exploration of the effect of topical vancomycin powder in neurosurgical patients has been brought to the forefront. Studies have shown IV antibiotics used during surgery can have fluctuating distribution to the surgical area, thereby decreasing the occurrence of attaining bactericidal levels. However, topical agents are more likely to attain large bactericidal level at the area of the surgical bed, which is needed to destroy unwanted organisms. Another appealing aspect of Vanc powder is the cost. A vial of Vanc powder can run anywhere from $2 to $12. So the purpose of the project was aimed to reduce post-craniotomy infection by incorporating vancomycin powder to the current surgical bundle we have in place at our institution. The clinical question I decided on, I guess, in patients undergoing craniotomy surgery, how does adding topical vancomycin powder to the standard prophylactic interventions of CHG wipes, intra and post-op IV antibiotics compare to utilizing traditional prophylactic interventions of the three? So I did two separate literature reviews. The first one was about in the other surgical bundles that are currently in place. I discovered that there were a total of 8 articles that I evaluated. Of the 8 articles, 5 were excluded. 3 studies were surgical bundles not specific to neurosurgery. 1 was excluded since no pre-op betadine wipes are used at our institution. And the last 2 were excluded due to it being a comparison of surgical infection rates based on the type of hair removal that was taking place. Our institution does clipping and nose shaving, and that's what those articles were about. The strengths and limitations, the surgical site infection prevention bundle were implemented to assist in decreasing postoperative infection rates. However, after evaluating the most recent research available for SSI prevention protocols, the data reveals surgical site infection rates continue to rise. Although surgical infection prevention bundles should be further investigated, since this method accounts for both elective and urgent cases, preparation of the surgical site and antibiotic use, the interventions have shown gaps in reaching the goals of decreasing infection rates. And that was just an algorithm on how I did my research. The second portion, I did a research on vancomycin to see what I could find for craniotomies. A total of 11 articles were identified. Of the articles yielded, 5 were excluded. 1 study related to a spine procedure. 3 were replies or letters to the editors. The last one was excluded due to the population being pediatric patients. There are very many theoretical frameworks out there. I chose Lewin's change model. The 3 main areas of this model is the unfreezing phase, where the surgical site infection task force met, discussed our current percentage rate of infection in our hospital within the neurosurgery practice over the past 2 years. Evidence was presented on vancomycin powder reducing infection rates, and the evidence convinced the task force as well as the surgeons that we should give it a try. The change was when we started applying the vancomycin powder to the surgical bed, and the refreezing was when we completed our project and continue to follow up with the staff and using vancomycin powder. So our population were patients who underwent craniotomy surgery. For my project, I couldn't mention, but we all know it was our institution in Jacksonville, Florida, between October 6, 2020 to May 22nd, 2021. And we did a retrospective analysis. The demographic analyzed was age, sex, weight, BMI, glucose, diabetes mellitus, coronary artery disease, dyslipidemia, smoker, current or past. Additional information included was steroids before the procedure, surgery indication, whether it be a tumor resection, hematoma evacuation, or cerebral vascular procedure, stroke-related emergencies, previous surgeries, skin prep, skin closure, dressing, estimated blood loss, intraoperative steroids, intraoperative antibiotics, surgical times, as well as length of stay and follow-up times. Our outpatient postoperative visits were also included so we could capture any late infections. And went through 2 IRBs, one at my university as well as the hospital. And they found that we did not have to go through a IRB review as well, since we were doing it as a retrospective study. Our stakeholders were our craniotomy patients, our institution, our task force, our surgeons. Organizational factors include the surgical site infection team monitoring infection rates. The SSI team held multiple discussions on postoperative infection rates and subsequently implemented strategies to assist with decreasing hospital readmissions related to post-invasive procedural infections. Quality improvement of patient outcomes motivates organizations to focus on lowering SSI infections. And lastly, organizations have a financial incentive as well. A reduction of infection rates results in an increase in revenue. After multiple meetings and discussions with the surgeons and the task force, that's when we started our project. Thankful for my research team because this is another language on data analysis. So the following is a picture of our vancomycin powder on our bone flap. And we did do chlorhexidine wipes within 24 hours of the surgery if it was non-emergent. If patient was in a life-threatening situation, we definitely skipped the wipes. Patients received at the time we did this project, ANSEF 2 grams per our hospital protocol within 30 minutes of the incision time. However, since that time, we have gone just to straight vancomycin through all of our patients across the board. Patients were prepped by the surgeons, typically using alcohol followed by a ChloraPrep or a DuraPrep. After the surgery was completed, the vancomycin powder was applied to the top of the bone flap. And in this picture is what you're seeing. It is just the powder, and underneath is the closure is already completed all the way to the skull. And this is prior to closing up the galeal level and using staples to close the skin or sutures. And after the staples or the sutures were applied, bacitracin was placed on the incision and covered by a TELFA, and the dressings were removed by postoperative day 1. And for this project, we just had across the board that staples or sutures were removed at post-op day 14. So a total of 351 patients met the pre-established criteria and were included in the project. Of this population, 141 received vancomycin powder after the surgery, while 210 did not. The mean age was around 60 plus or minus 16 years. Most patients were female. A total of 119 patients received steroids prior to the procedure, and 67 of the patients had a previous craniotomy. The most common comorbidities among study patients included hypertension, hyperlipidemia, diabetes mellitus, and coronary artery disease. Tumor resection was the most common indication for our craniotomies, followed by hematoma evacuation, and cerebral vascular procedures we just kind of put into one group. All variables were homogeneous between the historical group and the vancomycin powder group, except for CAD, which yielded a statistically significant difference of 0.047. Let's see. The technical features I mentioned earlier during skin prep, results demonstrated that alcohol was the most commonly used solution, along with dirt prep or chlor prep. Suturing was the most highly used method during that time for the skin closure, followed by staples, with more than 90% of wounds being dressed with bacitration. There was no clinical significance between these groups. Stop advancing. Is it not working? There we go. The procedural characteristics and follow-up, a vast majority of patients were prescribed steroids during the procedure and 348 received intra-op antibiotics. Cephalosporins at the time was the most used, followed by the vancomycin. And during the project, the reason why we used vancomycin is if they had a penicillin or cephalosporin allergy. There were no observed differences between the two groups regarding these variables. However, the results demonstrated a statistically significant difference between the length of stay and hospital follow-up between patients receiving vancomycin powder to the control group. The median length of stay for the control group was 4 days, and for patients who received the vancomycin powder was 3. For patients in the control group, the median time for the first follow-up was 25 days, while being 17 for the vancomycin powder. Finally, there were 6 observed postoperative infection cases in the control group and only 1 with the vancomycin powder group. The differences were actually not found to be statistically significant. There was one sole case of possible vancomycin-related complication, which ended up being a seroma. When we discovered that, the patient was admitted. We did get samples and sent it to the lab, and it showed that there was no infection. So all we did was we wrapped his head for 2 weeks, and when he came up to follow up, the seroma was completely resolved. So the project evaluated the effectiveness of vancomycin in preventing surgical site infections following craniotomies that aligned with the evidence-based best clinical practice. There are a few strengths in the design of the project, including similar baseline and procedural characteristics between the groups, standardized surgical procedures by 2 independent neurosurgeons throughout the cohort, and standardized patient care by a multidisciplinary team. The results demonstrated a lower number of postoperative infections in patients receiving vancomycin powder compared to the historical control group. The absence of a significant difference between the groups is most likely related to an overall low incidence of infection, ultimately requiring a larger sample size. Additionally, only a single case of vancomycin powder postoperative complication was noted, which reinforces the therapy safety profile. Limitations of the project include conducting a retrospective analysis versus a prospective randomized study. Additionally, the sample size in the variable arm was less than the control arm. Continuation of the study beyond conclusion of the project may reveal that it is actually clinically significant. Other rationales behind the patient returning with an SSI despite the vancomycin powder. We did have one patient who went to rehab and the incision had just totally opened up, and we were not notified by the rehab center that that had occurred, so that could definitely have played a role. Other things that had happened is there was a difference in terms of the post-op education. Some of the patients were coming back for their post-op evaluation, and they were told not to wash their hair for 2 weeks, and there was superficial infections that occurred at that time. Implications for clinical practice. hospitals across the country would benefit from a decrease in surgical site infections. A retrospective study revealed investing in a surgical quality improvement program addressing surgical site infections would decrease cost expenditures towards the issue. A large tertiary hospital allocated $600,000 towards the quality improvement of surgical site infections between 2010 and 2016. And in turn, they saved over $1 million. Not only did the hospital see a return of investment with a reduction of SSIs, the patient also benefited with a decrease of hospital length of stay, as well as not coming back with an infection. So how can this be applied to your own personal nursing career is one, helping us making sure that all of our pre and post-op orders are facilitated, including the CHG wipes, antibiotics, if they've been ordered. Typically, it happens in the pre-op area. Sometimes it's an emergency situation, and then it ends up having to be given in the OR. And then we do have orders at our institution to do our post-op day 2 hair washing. We try and facilitate that and ask the team, but it's definitely helpful. Implications for future research. The results of this project, it was done retrospectively, so it would be very interesting to see if we did it on a prospective randomized control trial to see if we would discover that there would be a decrease in infection. And also creating a research design that would include multiple institutions versus just our little hospital. Although the project was not statistically significant, the outcome of the study confirmed a reduction of infections with the application of vancomycin powder. And that was the goal of my project, was a quality improvement, and going from 6 infections to 1 while doing this project. I think we did succeed in what we set out to do. But more importantly, the patient outcomes will improve by decreasing the risks of sepsis, length of stay, and readmission rates. The addition of this retrospective project on vancomycin powder reinforces the need for extra studies. Any questions? Everybody's ready to eat?